Welcome back to electrocardiogram. So electrocardiogram can be abbreviated as ECG. So the main use of actually an ECG machine is to record the electrical activity of the heart over a period of time. It is very important in that it normally helps in diagnosing some of the heart conditions. So this could be arrhythmias, myocardial infarction, ischemia, sometimes even electrolyte imbalance, and even heart enlargement. So these are things that can be obvious within the ECG. Also very important in monitoring the heart function, evaluating some symptoms such as maybe chest pain, palpitation, dizziness, and shortness of breath, to tell us specifically, maybe with some specific clarity on why maybe patients could be having those symptoms. And also it is very important in that there are some patients who normally receive some implants or some pacemakers. So to assess the effectiveness of these therapeutic modalities, or rather things like pacemakers, you can also use ECG. So when it comes to ECG, we say that ECG normally has 12 leads. So 12 leads in a basic way is to suggest that from the 12 leads of the ECG, you expect a specific information. So maybe one of the main questions that should be there: why should we use a 12 lead in an ECG? This is very important because it normally gives a comprehensive view of the heart electrical activity, at least from different angles. Each lead gives a unique perspective, helping to localize problems within the heart. So they are very important. So if you can see from our image, this is actually a part of an ECG, only that it is not attached to a monitor. So if we go to the second image, you'll be able to see the monitor, what we are referring to. So you're talking of the ECG, you are talking, you should be able to remember the 12 leads, or we have the 12 leads. So like in the image, these are what can be identified as leads. So these are the types of leads that are normally in contact to the body to pick the particular electrical signals as it is anticipated, and then relayed to a monitor through this wire connection, almost similar to a VGA. So from a single lead, we'll be expecting a specific information about the heart to be relayed. And we've said that as somebody who will be interpreting the ECG, you'll not be over reliant on one lead, but you'll need to use multiple lead, so that should there be a problem in specific areas or in different areas of the heart, you are able to pick that adequately, unlike just relying on the one lead. So these leads are attached to the body, so specifically the right arm, the left arm, and the left leg. And we'll also be able to see at the intercostal space, fourth, V1, V2, and we'll also be able to see at the fifth intercostal space, specifically in the intersection of the mid-clavicular line, anterior auxiliary line, and also mid-auxiliary line. Those will be apparent. We'll be able to see specifically where these leads are normally placed. So maybe what we should be aware of when you talk of leads, when you talk of leads, so these are normally consist of electrodes. Electrodes can be negative or can be positive, and this gives us the three different type of leads that we anticipate in an ECG. For example, we've said that the ECG contains 12 leads. So this can be categorized into three main categories. So we have normally three bipole leads. So as the word suggests, they have two electrodes, the positive and the negative. We have three augmented leads. as the word suggests, suggesting, this is to mean that we have 2 electrodes and then we have an additional one, so we've augmented the 3, and we have the 6 unipole leads. So this means they have 1 electrode, so mostly the positive electrode. So these are now the V1, V2, all the way to V6. So if you count this will be 12 leads. 12 leads should be able to give us different graph as we anticipate in the ECG. So we've said that these electrodes that are consisting of leads, are leads consisting of electrode, that is, they are able to pick electrical signals in regard to the heart, and that information will be represented in a graphical form, and that will become our ECG. And maybe to remind us, we said that the ECG is likely to tell a different story of a cardiac cycle, but it does so in an electrical way, telling you how the impulse will be generated at the sinoatrial node, spreading to the atrium, atrioventricular node, the bundle of His, the Purkinje system, eventually up to the ventricle, so that in the cardiac cycle you are able to appreciate atrium and the ventricle contracting. So this is what you'll anticipate. So for example, the electrodes of the leads have been able to pick that electrical information. You expect them to be relayed on this monitor. On this monitor. So you can continuously examine this monitor, or it can be printed out so that you examine. So in the monitor we have specific graphical or electric graphical information about a specific type of lead. So we expect 12 types of graphs. So for example, if you examine it in a much clearer way, this is what you'll anticipate. So this is the sorry with that. So this is the lead 1. You're able to see lead 1, lead 2, lead 3. So they have various names. So we'll be able to specify or categorize. So for example, the bipole leads, we have lead 1, lead 2, lead 3. The augmented, we have the augmented voltage right, augmented voltage left, and we have the augmented voltage foot. And with the unipole leads, we have the V1, V2, V3, V4, V5, and V6. So this chunk of information actually contains data of the different types of the leads, so that as a cardiac clinician or as a clinician, you'll not just be examining one lead, even though most of us we are really aware of the lead 2 because of its clear distinction. You can clearly distinct various chambers of the, not chambers, but various areas of the heart. So this is lead 2. You can examine lead 2, you can examine lead 3, lead 3 here, lead 2, and these other leads, so that sometimes this could be normal, but maybe you are having an abnormality with the V6. The V6 should be, that means that the V6 will be telling a different story away from the lead 2 or from these other leads. So that's why it is very important for us to understand how they are. But in this session, we'll dedicate ourselves to maybe the normal physiological interpretation of these leads, or rather these graphs, electrical graphs, as displayed, or rather as collected with our leads. So before we jot out the normal leads, so it is very good for us to get some of these basics, some of the basic principles that might revolve around this graphical representation as you are able to see in your ECG. So what are some of the basic principles? So I want you to consider this image that you are seeing over here. Of course, this is an image of the heart that is contracting and relaxing. So let's assume you decide to be a little bit evil and take a piece of the take a chunk of the heart muscle, and you end up with something like this. So this is a piece of the heart consisting of maybe closely arranged cardiomyocytes, so that if one area is excited, the action potential will spread from one cardiac cell to another. So let's assume you've had your piece out, and in your piece you decide to attach electrodes. You attach a negative electrode over here, and you attach your positive electrode over here. And let's assume that this muscle cell over here has some action potential, and it is spreading in this particular manner. You are able to see action potential spreading from the negative into the positive, where we're having the positive electrode. This is not to suggest that they'll respect the way the electrode are placed. So you've just decided to place your electrode like this. You might even decide to put the positive in this direction, and the negative on the other. So ordinarily, what you'll anticipate. So in this, it is right to say that the wave of depolarization is moving from the negative towards the positive. So in a normal ECG graph, when this is taking place, positive charges moving from negative to the positive, an ECG is likely to give you something like this. This we said it's likely to give you an upward deflection. Still, maybe with the same piece of heart muscle, you can decide still to place maybe a negative electrode in this area, your positive electrode in this area. But this time round, you are having an action potential starting in this cell, spreading to an opposite direction. So I want us to note this and not forget. So this will be like our key, so that the wave of depolarization spreads from the positive to the negative. In the ECG machine or in the EKG, what we will anticipate is a downward deflection. Or let's write here downward deflection. So you might decide now to change the electrode. So maybe let's say this is positive over here. You place your electrode over here, and the negative electrode over here, and this is still the direction of the movement of the action potential that is marked with the positive charges, as we were able to say in our previous presentation. And this now becomes the direction. So what will this give you? This is going to give you an upward deflection. So maybe what I might want to bring out is, sometimes you can also get wrong ECG results or graphs depending on how you are placing your electrodes. So for example, if you place your electrode, maybe let's assume positive in this side is not the right manner, so it will give you an opposite thing than what you will anticipate. So we need to be cautious with that. So we not only have the positive charges moving, so sometimes you can also have some negative charges moving. So let's assume that this is negative and this is positive, so we'll use this letter. This is a positive electrode. So having that, we are having a wave of repolarization. So you can assume that these cells were previously charged and now they were previously positive and now they are being repolarized. They are being taken back to the relaxation state. So our wave of repolarization is moving from the negative to the positive. So write this. So what do we anticipate with this? It is just from simple physical determination. When negative charges move away from the negative towards the positive, this will give us a downward deflection. So the same with what we said, positive moving away from positive, same charges moving charges moving from a similar charge away from it, it will give you a downward deflection. So the same thing you anticipate over here. So we'll be able to see how the ECG normally behave following just this basic principle. So what do you anticipate? An upward deflection. So this we can still manipulate and maybe change the direction of the of our repolarization, maybe to the opposite side. If it's to the opposite side, you'll anticipate an upward deflection. So this was the downward. So from this we should be able to create many scenarios. It is also good to note that there comes a time where you can place maybe a negative electrode over here, or let's even decide positive. So let's just create two scenarios at a go, and maybe alternatively somebody else decide to place a positive over here and maybe negative over here. So these are two scenarios that we want to explain at a go. So sometimes you can have a state where we are not having net movement of charges. So the negative, either we are having the negative charges are not moving, in that the cells are just relaxed and they are not excitable, or in that the cells have just contracted and their contraction is sustained, so that we do not have charges moving. So in the ECG machine, how is it likely to represent this in a graphical way? It is likely to give us a straight line or an isoelectric line. In a straight line. So this is to tell you that both for clinician, there is no any charges that are moving in this ECG. So it is likely that maybe the cell has maybe died, in that it cannot be excited. So if they are not excitable, there is no way we will be having movement. Another explanation could be a particular cell is holding too much to these signals or these charges. An example is normally the atrioventricular node, where we say that an electrical impulse in the atrioventricular node, there is usually some form of delay. So it could be a representation of so let's just write here to be fully exhaustive. It could be a representation of delay. It could be a representation of tissue or cell death. And in this delay could be you are holding some positive charges. So one of the areas that is known to behave like this is the atrioventricular node and also ventricular muscles. This is to suggest that when they contract, their contraction is a little bit sustained, in that they tend to hold these positive charges a little bit before the wave of repolarization kicks in, and that might give us some of the straight lines that we'll be able to see. So still with this piece of muscle over here with cells, you can decide to place your electrode in a perpendicular manner. So let's assume that maybe you've placed your negative electrode on this side and have your positive electrode on this side. And let's assume again we are having a wave of depolarization spreading towards this particular manner. So here we'll create 4 scenarios at a go. So the wave of depolarization could be towards descending, or it could be ascending. So we just want to understand how that will be translated into an ECG machine. Or sometimes you could be having a wave of repolarization. In a descending manner, spreading in a descending manner. Or the wave of repolarization spreading in ascending manner. So all these 4 circumstances are likely to give us somehow similar scenario. This is because when these are actually aligned in a perpendicular manner to the electrical field created by the electrode, so this is the normal behavior. So for example, let's just choose one and see what happens. So for example, you choose the positive charges moving downward. So as it moves downwards, it might seem as though it is moving towards the center. So while it's moving toward the center, in respect to its charge, you will say that it is moving towards the positive. So this giving you a curve like this. So positive charges moving to the center, and away from the center, it will be dim as though it is moving a distance away from the positive charge, in that you can extrapolate this all the way down. So you'll say that it is moving away from the positive. So this will give you a downward deflection like this. So any complete movement of these charges, either negative or positive, it will when you approach the center, it will seem as though you are approaching a particular charge and then moving away from it. So you are likely to have this upward deflection and then downward deflection. So the ECG is very clever. It will not give you something like this, especially when you are having maybe similar amplitude. It is mathematically clever and it normally cancels off and gives you a straight line. So this telling us in the ECG machine, a straight line can also mean a straight line, or an isoelectric line can also mean that the electrode are placed in a perpendicular manner, considering the current of maybe depolarization or repolarization. If they are placed in a perpendicular manner, it's likely to give you a straight line. So a straight line does not necessarily mean a delay, does not necessarily mean a tissue death. It could also mean that the electrodes are placed in a perpendicular manner. So it is very good to acknowledge this, because sometimes before maybe interpreting an ECG, especially those who normally interpret it while still in the monitor, or they are monitoring the patient continuously, so you can actually confirm to see that these electrodes are actually placed appropriately, because if not, they can actually be a great or a very significant point, or rather source of error. So having that, we've understood that. So let's go straight back to our leads and know the specific area or how maybe we are supposed to be placing these leads, because we've admitted or we've acknowledged so far that if you place these leads, or rather these electrodes, in not the right manner, it can be a great source of error. And for us to avoid that, it is very, very compulsory for us to know how to place these leads. So while we were introducing, we acknowledged that we have three types of lead. We have the bipole leads, we have the augmented leads, and we have the unipole leads. The bipole leads are 3, the augmented leads are 3, the unipole leads are 6. So let us examine how they can be placed in the, of course, on the body, on the skin, and of course, again, we examine the electrical field that these electrodes can create, especially how they relate to the heart. How is the heart able to sense that electrical field actually generated by the placement of this electrode? So we'll start with the bipole leads. So let's just write here the bipole leads. So we've said that actual leads consist of electrodes. So in this case, we are talking of the leads that normally have the two types of electrodes. So that we know, the positive and the negative. So if you are to be given a lead, your main question should be, where do I place the negative and where do I place the positive? So for example, our first lead over here becomes the lead 1. So the lead 1 also has two, of course they have two electrodes, the negative and the positive. So how do you place the lead 1? So you take the negative electrode is normally placed on the right arm, as you can see in our image over here. So this is the exact area where you should be placing, somewhere at the wrist. The other electrode, which is the positive, you'll place it in the left arm. So for example, how is it likely to create this field? So let us assume that maybe you've extended this arm. So let's draw even a more cartoonish arm. Don't mind the drawing. So all this has been extended. I'll shorten this just for convenience so that we don't overwrite on our electrodes. So for example, with the lead 1, this is the right arm. You've placed your, this is the negative electrode. You've placed it over here. And this is the left arm. You've placed your positive electrode. So you can actually join this. And name this lead 1. So when it comes to heart affair, so again, let's just draw a rough sketch of the heart, acknowledging the chambers, so the heart is likely to perceive these charges, negative here, or the positive and the positive, as the lead 1. So we'll be able to see how these are very essential in explaining how signals are moving from the sinoatrial node and eventually to the ventricle. So we also have the lead 2. So how do we place the lead 2? Of course, these also have the negative and the positive. So where do you place the negative electrode? So the negative electrode is again placed on the right arm. while the positive electrode is placed on the this time on the left leg. So it should not be confusing. So this is normally just a neutral. No real electrode is normally placed on the right leg. So assuming this will be having some positive charge over here and will be having some negative charge over here. Not here. This is the left, so it should be on this other side, the right arm, so that if you join this together, this will be the lead 2. To make it closer to the heart, so this is what it will seem. You can put something like this, so the lead 2 can give you something like this in relation to the heart, and this the lead 1. We also have the lead 3. Let's just construct to the Romans, where we have the negative electrode. The negative electrode, you'll place it on the left arm, and the positive electrode, you'll place it on the left leg. So giving us something like this, positive and negative for the lead 3. So you extrapolate, you join this, you'll be having your lead 3. So in relation to the heart, here is another positive, another negative. This is how the heart will be caged in this electrical field. So a more clearer picture in terms of what we'll have. So this is what we'll end up with. The lead 1 giving us these perceptions of electrical image placed on the heart, in that you cannot just place directly on the chest near the heart. You just want to place them on the arm, but you see that electrical field will just be spreading if you join the left leg and the right arm, so that near the heart, this is what it will give us. So that when we'll be coming up with an ECG, so maybe while focusing on a particular lead, for example, in our case, we'll be focusing on the lead 2, as the action potential is spreading from the sinoatrial node to the atrium. So towards this direction, you'll be able to say that it is moving away from the negative onto the positive, and we'll be able to see what to jot in our graph. So let's examine our second types of lead. So in this group, we have the augmented leads. So some people can refer to it as Goldberger leads. So we actually have 3, and they have 3 electrodes. So this consists of the augmented voltage left. So let's just abbreviate our first one over here. Augmented voltage left. So as the word suggesting, you are augmenting a particular voltage, and maybe for because we have two negative electrodes and 1 positive electrodes. So when you hear the left augmented, just know that the positive electrode is actually placed on the left arm. So let's see how we place this electrode. So we're starting with the positive, where we've said that you placed it in the left arm, and the negative. So remember, we are not using the right limb. So whereby the 2 negative, one on the right arm, and one on the left leg. So what electrical field will this give us? So remember what we had with the bipole leads. For example, let me talk of the lead 2. So the lead 2, we had some negative in this spot, negative, and some positive, so that it seems as though this is our lead 2. So let's see how we'll be able to represent these augmented leads. So we, at least by now, we can be able to say how we are coming up with the triangles. So the left arm, of course, it's here, the right arm, and the left leg. So this is the augmented left. So you can join something like this, having the 2 negative, 2 negative, 1 positive, so that you join something like this. So this is what you're likely to get with the augmented left. And because we are having 2 negative, so we cannot just be flowing in a 2 direction, or from this direction to this. So we need to get a middle ground between these 2 negatives. So it becomes this area, so that you'll be having your charge flowing towards this. So this becomes the negative. So if we are to have a real summary, or rather a real representation of the augmented left, this is how the charge will be: positive on this area, and then negative on this area. So this is what you are likely to get with the augmented left. So if you are to place it with the other leads, so for example the lead 2, where we had the negative on this part and the positive on this, it will seem as though this augmented are just attempting to intersect these other leads. So the real summary in terms of the lead, the augmented AVL, or the augmented voltage left, this is how it will seem. So the image that we are given after placing the electrode, but to get an electrical summary, this is what you have. So let's move on to the augmented right. Can actually abbreviate it as the augmented voltage right. So this will suggest that the positive electrode is placed on the right arm. The negative electrode is placed on the left arm, and the other negative is actually placed on the left leg. So this will give you again something like this. So positive on the right arm, but negative on this other part, negative on the part of the foot. So it should be somehow be able to create something like this. So joining all your electrodes and get the middle ground between this negative, so that you have something like this. So in summation, you should be able to have something like this, a positive and a negative. So let's just have a summary in, let's just draw our heart over here and be left with what maybe we'll anticipate. So let's return back what we had, the lead 1, and we are having the lead 2 as we suggested, and if you put here negative, and of course another positive, we'll be having the lead 3. So this is what we had with the bipole. But when you introduce the augmented left, what we've seen is actually some positive over here being shared, and then the presence of another negative in this particular area. So this is the augmented left. What we are seeing with the augmented right over here, they are retaining some positive, but in between this, because we are having the negative placed on the left leg, we are finding a middle ground. So this becomes the augmented right. So this is telling us that it will be giving us more information about this particular area. So we also have another type of augmented lead. So this is called the augmented voltage foot. As the word suggests, we are having 3 electrodes. The positive electrode this time around is placed on the left leg, while we are having the other 2 negative electrode, this on the right arm and the other negative on the left arm. So you'll be having something like this, negative on this right, negative on this left, and on the foot you anticipate positive. As we've suggested, we need to have a middle ground of the negatives in terms of summary. So this is how it will look. So if you summarize this, you are likely to have some negative and positive to seem as though it is moving in a perpendicular manner. So if you place this into context, you can have something like this, the positive and the negative. And of course, this is still the positive. So you are able to say lead 1, lead 2, lead 3, and also you are also able to say the augmented left, augmented right, augmented foot. So maybe what we need to know as we are continuing, we suggested that it is very important for individuals to understand different leads as it pertains to an ECG, in that different leads will give us different perspective of the heart. So for example, you can think of these positives that are there as maybe something like an eye. So this telling you it is likely to give you the information of the heart muscle, specifically on this area. This positive, it's likely to give you more information about this area, and this positive is likely to give you more information about this area. So let's move to the unipole leads, and we'll also be able to see, we said that the unipole leads actually are consist of 1 electrode, and we'll see the way they are placed. So we'll be increasing the perspective of the positive. So we'll be having different dimension with which we can be able to view actually the heart. So let's move on to the unipole. Unipole leads. So we say that these have 1 electrode. So this can again be identified as Wilson central terminals. So as the word suggests, or the abbreviations, so they normally tell us a lot of information in regard to the ventricles. So this can be from the V1, V2, all the way to the V6. So how are they placed? So let's start with the V1. Where do you place your V1? So the V1 are normally placed at the fourth intercostal space. let's write over here, fourth intercostal space, where the space meets the sternum on the right. So that is if this is to be a sternum. Almost looking like a tie. So on the fourth intercostal space, this is where you anticipate to place your V1. So how do you place your V2, or where do you place your V2? Again, at the fourth intercostal space, where the space meets the sternum, specifically on the right or to the left. So this is where you place your V2. The V3, we are told that you place it somewhere between V2 and V4. So before we place our V4, let's find out where we place our V4. So this is normally placed at the intersection, intersection of the mid clavicular line and the fifth intercostal space. So that this will be a representation of the clavula. So let's write a clavula over clavicle over here. So the mid, where it intersects with the fifth, so this becomes the V4. So that in between you place V3. So let's write over here. So where do you place your V5? This is placed actually in the intersection between anterior auxiliary line and the fifth intercostal space. So this suggesting that this V5 will be in a more lateral spot. So somewhere still in the same plane of the fifth intercostal space, but in a point where they intersect with the mid, not mid, but the anterior auxiliary line. So placing our V5 over here. So where do you place your V6? At the intersection between of course the mid auxiliary and the fifth intercostal space. So this will place it in the same plane but somehow posterior. So for us to get that 3D effect, so let's put it somewhere above. So this is where we are placing our V6. So this is likely to give us again a lot of information specifically about the heart, specifically in the ventricular area. So for example, how are you able to see this unipole series or rather leads placed? So for example, if you are to take the cross-sectional surface, so in a plane, so let's have something like the spinal cord. Might not be perfect, but assume it's 1. Just have a rough picture of the same. Say this as spinal cord, sprouting out rib. Now should be sprouting out ribs to merge anteriorly with the sternum. Or not a so-called perfect circle. Okay, perfect a little bit. And so that we just get how these V1s up to V6 are placed, so that you can have that lateral sense. And then let's place our heart somewhere on the left. Of course, not the real shape, but you are able to get the anatomical position or the anatomical sense. Let's have our right ventricle over here and a little bigger at the left ventricle, so that we are having V1 over here, V2, V3, V4, V5, and V6. So somehow placed in a lateral section. So these are positive electrodes. So we say the positive, it's a representation of the eye. So it is likely to tell us information, mostly information as it relates to the ventricle. So this is the right ventricle and the left ventricle. So this is how we expect the ECG leads to be placed, specifically the electrodes, the specific anatomical areas on the body surface where we anticipate them to be placed. And it is from that they are likely to create some electromagnetic or an electrical field as far as heart is concerned. For example, when you're having a negative electrode over here and a positive electrode, so just ignoring where either the wave of depolarization or repolarization, ideally in the electrical fields we normally have electrons moving from the negative to the positive. So whatever we are getting in the graph is just how this movement of electrical field synchronized with the normal depolarization. So if they are moving somehow in the same direction, the positive towards the positive, giving us an upward deflection. If it's positive, again with the same story, same as what will apply to the negative charges as we said. So we are only able to give the ECG graph based on the electromagnetic field created by the electrodes that gives us a deflections or an isoelectric line based on how they correspond to the normal electrical movement of electrons based on the electromagnetic field created by the negative and the positive electrode. So let's choose one of the leads. So lead 2, we say that this is the most common, and we see how we'll end up with a normal ECG curve, of course, to give us an electrical perspective of the cardiac cycle. So before we extrapolate, we'll actually draw the conductive system just in a reminder. So let's place our sinoatrial node over this particular area. Of course, from here you expect signals to spread to the atrium. and signal from the atrium cannot go to the ventricle directly. This is because we have some barrier that normally houses this atrioventricular valve. So this is referred to as the annulus fibrosus. So electricity or the electrical impulse cannot just move freely from the atrium into the ventricles. So they'll need to pass through the conductive system. And this is where now we are placing our atrioventricular node. So that means signal from the atrium or from the sinoatrial node will need to pass through the SA node. And so from the SA node, we'll spread that signal straight to the ventricle. So we're having two major branch. We have the right, we're having the left. So let's write the left major branch, and we're having the right. So of course this will continue to subdivide up to the Purkinje's fibers, that of course it's likely to spread the action potentials into the ventricles. So for example, in our ECG, we are still in reference to what we suggested while beginning our lesson, cardiac cycle. So the events that happen between one heartbeat to the next heartbeat. So more specifically, the electrical events. So this is what the ECG seeks to establish. And these events could also just mean story or the journey of an action potential from the SA node spreading to the atrium, to the atrioventricular node, spreading to the through the bundles, and eventually through the ventricles. So this electrical journey is what we want to represent in our ECG, and the same representation can be represented by every type of this lead, from the lead 1, lead 2, lead 3, the bipole, the augmented, and also the unipole. But what we've chosen as a demonstration is just the lead 2. So the expectation is, after we've demonstrated with the lead 2, in your own groups or in your own individual time, I'll want you to extrapolate the same with the other different types of leads, whether the V or the unipole, the augmented, and also maybe whether 1 or 2. Okay, so into context, let's place our lead appropriately. So we are dealing with the lead 2. We said that in the lead 2, you normally put the negative electrode on the right arm. So this is likely to give us something like this. And on the left leg, you'll put the positive electrode. So as far as heart is concerned, it is able to, the electromagnetic field is actually flowing from this direction towards this. So if our action potential maybe are moving in the same direction, so we'll be able to see whether that will be an upward or a downward deflection. So let's start with our action potential. So we know very well that most action potential normally start in the sinoatrial node. So from there, the charges are expected to spread to depolarize the whole of the atrium. So this is the wave of depolarization, starting from the sinoatrial node and spreading to the whole of the atrium, so that at the end of the that depolarization, the atrium is fully contracted, and we say that this is syncytium, likely to contract as a unit because of the gap junction or with the intercollected disc that we examined in our previous section. So we are seeing the way the depolarization wave is moving. So we suggested that the depolarization wave can actually be, we can represent them with some plus. So how are we moving? So the plus is moving towards these directions. So we are able to see spreading from this particular area, so that the whole atrium is actually depolarized. I hope that is clear. So if you are to take this movement of these charges, most of them seems to be moving in these directions, but I want you to get the summary or the vector movement of these electrons or of these impulses. It will seem as though, if you summarize all this, it will seem as though it is having the tendency to move towards this particular direction. So I hope you are able to see that, even though it's dark, but just focus a little bit. It will have the tendency to move towards this direction. So let me just change the color. I think white will do. White will do. But we'll just be changing that. So it will seem as though it is moving towards this direction. And what is that suggesting? Positive. The positive charges are moving towards the positive. I hope you are able to follow that. The positive are moving towards the positive. This is when the atrium is contracting. So in our normal ECG, this should be able to give us the what we call the P wave. And in anticipation, we'll actually be anticipating some upward deflection. This is because we are having the positive moving towards the positive. So in an ECG, expect something like this. So this representing the depolarization of the atrium. So this is normally regarded as the P wave. This is because we are having positive charges moving towards the positive. So what happens after there? So when the atrium is fully depolarized, signals normally spread to the atrioventricular node. So what is the behavior of the atrioventricular node? There's usually some form of delay, and this delay is very crucial, at least to give the ventricle time to fully relax, so that at least it can receive adequate blood. So this means that we are having some positive or some action potential, but the atrioventricular node has the tendency to delay the movement, so it is holding them a little bit before deciding to let go. So that's what are we likely to see in our ECG graph. So as the atrioventricular node decides to hold our positive impulses, this is what we'll be having. So this should be the PR segment. Let's just explore it. That means AVN, atrioventricular, holding on to positive charges. We've said that the P wave is representing an atrial depolarization. Of course, when the depolarization waves comes, as a muscle you contract. So after a period of time, around 0.8 seconds, the atrioventricular will decide now to release the signal, so that we have our wave of depolarization spreading. So it normally spreads to the right and the left bundles. But before the ventricles are actually depolarized, the first area to be depolarized is normally the septum, the ventricular septum. And the ventricular septum is normally depolarized by the left bundle branch. So having that, you are having the wave of depolarization spreading from the left going to the septum. So see the way they are oriented. So it means that waves will be moving from this area so that it eventually depolarize the whole part of the septum. So this is how it will look. So this is how the depolarization is spreading. So using this branch over here, while in the branch, some of it now spreads back to the septum. So if you take this, it will seem as though we are having some positive charge moving towards this direction. So if you jot this direction very well, it will seem as though the positive charges are moving away from the positive charges. So what kind of a curve do you anticipate? You expect a downward deflection, and a downward deflections gives us our famous Q wave. Right here, the Q wave. So the Q wave, what does it represent? It represents intra, or not really intra, but ventricular septal depolarization. So having that, now we have our ventricle, not ventricle, our septum depolarized. We'll now proceed to depolarize the ventricles. So this applies to the left and the right ventricles, and of course they are being depolarized by these branches over here that will subdivide into the specific His and the Purkinje system. So the wave of depolarization should be like this. On the left, it will spread towards this direction. You are able to see. So let's again use our white color for clarity. The dark, it's too dark. It's too dark for the heart. So the wave of depolarization spreading, so that eventually the whole ventricle is depolarized, and the right one, of course, will be spreading like this, so that the whole right ventricle is again depolarized, courtesy of the conductive system. So in that, we are having significant movement of these charges. So we are having some moving towards left, some moving towards the right. But what you need to remember as a person, or as a clinician, or as a medic, the left ventricle is normally thicker than the right ventricle. So it means that you are likely to have significant electrical signals towards this side. So if you take the summary of this, or rather the vector of this movement of these electrons or charges, you are likely to end up with something like this. So for emphasis, let's revert back to our dark. Are likely to have something like this. This representing how you depolarize your ventricle. So a little bit leaning on the left. This is because the left is kind of thicker. So if the right was thicker, maybe you would have had an alternative of something like this, or just narrow. But even this will still be movement of positive towards the positive. So just like we are able to see from here, we are having positive, or the action potential summarized as positive charges moving towards the positive. So which deflection do we anticipate? An upward deflection, and it's a little bit much taller. This is because in terms of amplitude, this is because of the big muscles that you expect in the ventricle. So let's just revert it, rub it a little bit. We're going to rub all of it. So let's just put it up to the baseline. So this becomes the R wave. The R wave is actually a representation of ventricular contraction. ventricular contraction, or in matters electricity, depolarization. So that means you've managed to depolarize your ventricle. But what you need to remember, the ventricles has been depolarized, but we are yet to depolarize the base of the heart. So the base of the heart, or rather the base of the ventricles, just the posterior part. So we've depolarized the ventricle up to this particular area. So we'll need to depolarize the base area. So this is the base area. So let's read back to how it ought to be. So how are we going to depolarize the base of the heart? So that means upon depolarizing the ventricle, the wave of depolarization is expected to revert back so that the base of the heart is depolarized. So when the base of the heart is depolarized, we'll say that the ventricles are now fully depolarized, because we know the base of the ventricles extends to the posterior. So this is normally, we'll have positive charges moving to the opposite direction. So the vector movement is likely to be something like this. So positive moving away from positive in respect to this. So remember, we are referring to, our reference is the negative and the positive of the lead 2. So we will be having the same story for a lead whose positive is in this. For the example, the right augmented, where we are having positive and here maybe negative, we'll be having a completely different story. Maybe you could be getting some downward deflections, so you'll be able to jot that out. So this is how it's likely to seem. So as you polarize the base of the ventricle, you are likely to get a downward deflection, and this gives us our famous S wave. S wave, what does it represent? The depolarization of the bases, or rather of the base of the ventricle. So remember, in our introductory, we said that the ventricle also has the tendency to hold on to some charges. So when the ventricles are depolarized, you'll say that the ventricle and the bases of the ventricles are depolarized. You'll say that the ventricles are fully depolarized. And before the wave of repolarization comes, they have the tendency to sustain their contraction. So they can hold on to these positive charges before letting go. So this will represent a period of time where the positive charges are there and they are not moving. So it is likely to give us an isoelectric line over here, and this becomes the very famous ST segment. So the ST segment, what does it represent? Total contraction, where ventricle is holding on to the positive charges. So after it has held on to these charges, again we'll be having now the ventricles, or rather the heart, depolarizing. So how does the wave of depolarization normally spread? So just from the bases, it will spread from the base, the last point, spreading to the ventricle, spreading to the septum, and eventually up to the atrium. So the repolarization wave, how is it likely to move? It is if you take the net vector, so from this area, considering some also moving from this towards this direction, and then again they converge towards this direction. So it is likely to seem as though we are having the net movement of negative charges toward this direction. And because we are having negative moving towards the negative, what kind of curve do we anticipate? An upward deflection. An upward deflection representing the T wave. So the T wave, what does it represent? The repolarization. Polarization of the heart. So this we are not taking in specific segment, just repolarizing the heart completely. And how is it spreading? From the base up to the atrium level. And that's why we are having this upward deflection. And of course, after that, we'll be having a straight line, a period of inactivity, before another action potential starts at the atrium to give us another P wave. So here you can have the repetition P wave, PR, Q, R, S, T. So this period is called the refractory period. Period where another action potential is not possible. So the cell need to actually rest after repolarizing. So repolarizing, we are moving from the positive to the negative. While at the negative, we need to stay in the negative for a while in a relaxed state. So that represents the refractory period, or the point at which the heart relaxes. So this period is also very important. So maybe what you can be able to notice is, in our part 3, we'll be able to explore, maybe we'll be able to jot the specific graph. How do you interpret a normal ECG? How are you able to determine the heart rate, the voltage, and also maybe you can go deeper and now try to see how various conditions of the heart might be able to change these waves. So for example, think of the P waves. So what are some of the things that might change the P wave? So for example, think of some mitral stenosis or some tricuspid stenosis. So this area is likely to dilate and it's likely to hypertrophy. So with hypertrophy, sometimes the contraction is likely to be a little bit more massive. So in your ECG, what are you likely to anticipate? You are likely to anticipate something of a bigger amplitude, maybe a much taller P wave, a much longer P wave, or sometimes it disappears. What does it mean when you get the double P waves? So there are many perspectives now depending on the disease context. Before we end, I'll also it is very important to note, or rather to appreciate, that the ECG can also be affected with things like the potassium, the sodium, because we say that our action potential is actually the distribution of this at the cell membrane, the calcium, chloride, and also things like magnesium, also very important. So in our second part, maybe we explore the normal interpretation of the normal ECG, focusing on the lead 2, and also maybe some of the common conditions that maybe somebody can